Hello everyone, today we shall be discussing appendicular mucinous neoplasms or appendicular mucoceles. Now many a times these appendicular mucoceles are associated with confusion in the management. To start with, we will first discuss the presentation. Now, asymptomatic is actually the commonest mode of presentation. 50 to 51% of cases they will remain asymptomatic. They are usually detected during the diagnostic laparoscopy or a laparotomy being done from other reason. Appendicular lump in the right iliac fossa lump, they are the presentation in a small percentage of cases. Acute appendicitis is a mode of presentation in 8 to 10% of cases. Radiological investigations are done to rule out appendicular neoplasms, to diagnose appendicitis and to rule out other right iliac fossa pathologies. Now, while doing an ultrasonography, there are few red flag signs which will tell us that this might be a case of appendicular neoplasm. What are those? Very thick appendix, mass lesion, especially more than 2 cm at the tip, body or base of appendix, presence of mucinous ascites. This is very important. Presence of echogenic material or mucinous ascites in the pelvis is an important red flag sign to which will tell us that this might be a case of mucinous neoplasm with perforation, right? CECT whole abdomen is another important investigation which clearly demonstrates the mass lesion or the lump, exact diameter, extent, periappendiceal lymph nodes, presence of mucinous ascites, right? So all these can be seen in CECT abdomen. Tumor markers, two important tumor markers, CA 19.9 and CEA is often raised in pseudomyxoma peritonei and other varieties of appendicular neoplasms, right? So whenever you have a suspicion of appendicular neoplasm, get these tumor markers done. Now, to decide whether to go for an appendicectomy or to go for an right hemicolectomy. So this surgical decision is often confusing, and which operation is to be done. Now, there are three possibilities which we can do is an appendicectomy, simple appendectomy, cecal resection with appendix and right hemicolectomy. Another operation which is nowadays recommended is CRS in and HIPEC for appendicular high-grade neoplasms, for appendicular adenocarcinomas with peritoneal spillage, right? So these are the four options which we need to do in a case of appendicular neoplasms. Now, often these patients will require a second surgery because you are preparing the patient for appendicectomy in the background of acute appendicitis. It is difficult to arrange the OR facilities or to counsel the patient for a major surgery. So here, during the first surgery, you go for appendicectomy and go for proper diagnosis of the local involvement, right? Now, what are the principles during the first surgery? At any cost, we should be avoiding spillage because a non-perforated appendicular mucinous neoplasm is a benign disease, but a perforated appendicular mucinous neoplasm is a malignant entity. So at any cost, we should avoid spillage. During the surgery, we should take care to achieve a negative margin. If you have the facility of frozen, go for a frozen section of the base, and to achieve, you need to achieve a negative margin at any cost. The mesoappendicular nodes, they are to be inspected during the surgery. If you find them clinically palpable and visible, take sampling. If negative, go for a frozen section biopsy. The basic idea is you need to see whether these mesoappendicular nodes are positive or negative. Now, if there are free fluid in the abdomen, presence of mucinous material inside the abdomen, always sample it. If you don't find any sample of specimen of mucinous lesion or mucinous ascites in the pelvis, go for a peritoneal wash and send the fluid for cellular mucin, because in presence of mucin only, we don't have to go for HIPEC. But if there are epithelial cells with mucin in the ascitic sample, then we need to subject the patient for subsequent CRS and HIPEC, right? So during the first surgery, your aim is to avoid spillage, go for a negative margin surgery, because a tumor in the tip of appendix or in the body on the appendix with a negative base is good enough, is a sufficient surgery for low-grade appendicular mucinous neoplasms, right? Mesoappendicular nodes, you need to sample it, and all fluids from the abdomen are to be taken for samples, right? Now, usually these are two-step surgeries. The first step, you go for an appendectomy with a negative margin, avoid spilling and fluid sampling and mesoappendicular nodes, right? Now, based on the report of these findings, this patient may or may require a second curative surgery, right? Now, what are the algorithms for the management of different appendicular neoplasms? If it is a polyp or adenoma, you go for simple appendectomy, right? The next entity is low-grade appendiceal mucinous neoplasm or lamen. So, low-grade appendicular mucinous neoplasm. If they are non-perforated, go for appendicectomy only. See the importance of perforation, because all these tumors are classified, the algorithm is based on whether it is perforated or not perforated, right? So, if it is a low grade, no perforation, only appendicectomy is sufficient enough. If it is low grade with perforation, if the perforated material contains epithelial cell, go for a CRS HIPEC, cytoreductive surgery with hyperthermic intraperitoneal chemotherapy. But if there is presence of mucin only, no epithelial cells, then appendicectomy is sufficient enough. Okay, so low grade, if there are no perforation, go for appendicectomy. Perforation, go for CRS HIPEC, right? If it is a high grade one, high grade appendiceal mucinous neoplasm, again, if it is not perforated, go for right hemicolectomy. So, high grade appendiceal mucinous neoplasms, even if they are not perforated, we have to go for right hemicolectomy, because the management is like adenocarcinoma colon, right colon. Okay, if high grade appendicular mucinous neoplasm with perforation, then it behaves like a systemic or peritoneal disease. So go for right hemicolectomy with CRS and HIPEC, right? So this high grade mucinous appendicular neoplasms, they actually behave like adenocarcinoma colon. Okay. The next is the mucinous adenocarcinomas. Their management is more or less like the colon cancers. So if they are not perforated, go for a right-sided hemicolectomy. If they are perforated, go for a right hemicolectomy with CRS and HIPEC. So high grade mucinous neoplasms or mucinous adenocarcinomas, they behave as Ca colon. Only difference is if you have a peritoneal spillage, you need to add CRS hypec along with that. Now neuroendocrine tumors, these are rare tumors, but at your surgical practice you might encounter them. Here the principle is size criteria, 2 centimeter. So if it is more than 2 centimeter with a Ki67 more than 20%, Ki67 is a proliferation index, right? So if you have a high proliferation index along with more than 2 centimeter tumor, then you need to subject the patient for right-sided hemicolectomy or right hemicolectomy. If the patient is having less than 1 centimeter tumor, clear margin at the appendicectomy is achievable. Mesoappendiceal invasion is very small, less than 3 millimeter, right? No angio or neuroinvasion and low Ki67. If these points are present, a simple appendicectomy is sufficient enough. So less than 2 centimeter, right? Margin negative, no mesoappendiceal invasion or invasion less than 3 millimeter, right? No angio or neuroinvasion, Ki67 less than 2%. So if all these favorable points are there, go for appendicectomy only. If any one of these is positive, go for right hemicolectomy. So that's the principle for neuroendocrine tumor of appendix. Another rare tumor is carcinoid, right? Here in carcinoid, the principle is, again, it will depend on the perforation or not perforation. If you have a perforated appendicular carcinoid which is small, 20 millimeter or less, Tang A group, right, and having a mesoappendiceal invasion less than 3 millimeter, no angio neuroinvasion, Ki67 less than 2%. So these criteria are more or less like the neuroendocrine tumor. Here, if it is not perforated, appendicectomy only. If it is perforated, appendicectomy with CRS hypec. But if this goes as more than 2 centimeter, margin is dubious, positive margin, mesoappendiceal invasion more than 3 millimeter, angio neuroinvasion is present, Ki67 is more than 2%, or Tang B or C group, right? So here the criteria is more or less like neuroendocrine tumor along with the Tang A and Tang B and C, right? So Tang B and C is basically, these are carcinomas arising out of carcinoid, right? So here if you have a no perforation, go for right hemicolectomy. If there is perforation, right hemicolectomy along with hypec, right? So the principle is, if you have a low grade appendicectomy, whenever there is perforation, you add CRS hypec, right? Whatever the grade is, whatever the type of cancer is. But if it is high grade or mucinous adenocarcinomas, they behave as Ca colon, right? So right hemicolectomy is indicated in these two groups, whatever the size of the tumor is. But if there is perforation, go for CRS hypec. Neuroendocrine tumors more than 2 centimeter with high Ki67, go for right hemi. Less than 1 centimeter, having a good margin, no angio or neuroinvasion, low Ki67, less than 3 millimeter mesoappendiceal invasion, go for appendicectomy only, else go for right hemicolectomy. Carcinoid, more or less like neuroendocrine tumor with a Tang A and Tang C, B and C category, they are divided into whether to go for hypec or appendicectomy only or appendicectomy plus minus CRS, right? So that's the principle of management of appendicular mucinous neoplasm. So with that I conclude. Thank you very much. If you have any queries, you can mail me at this mail ID. Thank you very much.